Good morning, everybody. Gentlemen, thanks for making it into Delray Beach. Dr. Sai, you're joining us from our early morning out in Fremont, California. So I appreciate everybody being here today.
Thanks, Joe.
Thank you.
Yeah, and I'm excited about this because we're going to be talking about an emerging phenomenon, and I believe in medtech, and that's where we're at right now, is in particular robotics, orthopedics, implants, and what's going on in the market today. We're clearly at an inflection point. We were chatting before the cameras come on about if you said orthopedic robot, we all have in our mind what that meant, sort of is ossified, no pun intended, in the dictionary of orthopedics, and it looked like a Mako large form factor robot. And that's changed a lot just in the last few years, and especially with what we'll chat about this morning, what Think has done with TMINI. So Dr. Tiberi, I want to just open up with you. How do you think about robotics as a surgeon? How do you think about it from the patient perspective and the business person's perspective at 30,000 feet?
Yeah, I think it's it's really a combination of factors. It's it's a planning, it's an intraoperative information tool, right? I mean, something analogous to what used to be navigation, and then you add this execution component. So you could look at robotics as the execution piece only. You could look at it as everything. And it's both. Without the execution component, you wouldn't have as much enablement to act on the other two. But it really is all inclusive of all three things. When I'm doing a surgery, let's say a knee replacement, there's two parts to that. There's technique and there's implant, right? And it's not one thing. It's not what's the best technique, what's the best implant. It's what's the best combination, what's the best sum of the parts for me to deliver to my patient. And, now, especially with this system, I really have the ability to tailor that to what I think is the best for patients in general or for an individual case. So as a clinician, at least as a surgeon, that's kind of how I think about robotics and the components that go into it. But what makes it different, I think, than other technologies, non-robotic technologies, is the execution component that not only delivers the execution in and of itself, but also helps leverage the other pieces.
Dr. Saab, same question to you, a little bit of a spin on it. When we think about robotics and we go back 5-10 years, it tended to be a monolithic thought versus the fidelity of technologies that have come out before because of imaging, because of pre-op planning, right? The activities intra-op, and now the implant. How do you think about robotics in the recent past, today, and in the future?
Yeah, it's interesting, Joe. Things really have evolved with the use of technology in orthopedics. A lot of these robotic platforms haven't changed much, actually, but how we've used them in the operating room have changed, and what our understanding is of, for example, our bone resections, our bone cuts, our soft tissue balance. We're using these technologies in different ways now. So that's really evolved our technique, even though the hardware traditionally hasn't changed significantly. But now that our understanding has evolved with time, I think surgeons are using these technologies in different ways to achieve better outcomes for our patients with better implant positioning and better soft tissue balance.
And do you find that having these newer systems have an agility to them, tap into the creativity of the surgeon? Because now the surgeon is really, we've got the patient as the customer, but we really have the surgeon and his or her care team and work team as voice to the customer. They're now giving you what they'd like to see moving forward versus the first iteration of, here's your robot, figure out how to work it, and here's your implant that comes with it. I'm being a little sort of gross with that statement, but that's how it came on the scene.
No, you're absolutely right. When robots first came into the market for orthopedics, really the tool was for precision bone resection. Really, it was a technology meant to let us make good bone cuts. That was basically it. But things have evolved to the point where now we have better understandings of patients' individual bone phenotypes, different alignments, different soft tissue balance. And we just didn't know what the target was before. But this technology is now allowing surgeons to have a better sense of what's best suits the individual patient. And now we're able to execute these individual plans for each case.
So Chris, Dr. Sa just talked about, hard tissue robotics, and what's fun is you've come from the soft tissue world, from the organization that really started it, and now you've made this transition into hard tissue. So let's start historically with soft,
Sure.
and what are the lessons you're carrying over and maybe seeing now in hard?
Well, what was interesting in listening to both Alex and John talk about what's happening today in orthopedic robotics from their perspective is that I only thought about the form factor being large form factor. So, of course, coming up through intuitive, robotics was defined as a multi-arm system, and it looked like what you would think a surgical robotic should look like. And that, for me, was what it was. And then I joined Mako in late 2011, early 2012, before the Stryker acquisition. And of course, it looked like a surgical robot. It had an arm, an endomechanical end effector, and that's what I thought it was, and that it fit my worldview. What I learned over the course of the next really 10 years in orthopedic robotics was that the execution, the ability to execute the plan that was that the system enabled, was where the magic of the robot really was. And I think that thinking is what led to ultimately the thought that we could change the form factor. That in fact it didn't have to be a 900-pound robot that the surgical care team had to work around. That Dr. Sa and Dr. Tiberi and their teams could plan the case in the same way that they planned with Mako. They could execute it in the same way that they were used to executing in how they were trained with manual instruments and the execution pattern that they always had. And I think that's what's changed over the last 3 years with Think Surgical and TMINI.
And what's interesting is, some are a fan, some are not. I'm a fan. When you think about Elon Musk, and I'm going to bring him into this conversation, one of the things he always says is, should we still be doing this? And if we should still be doing this, should we still be doing it the way we're doing it? And that's what TMINI has introduced into the realm of hard tissue robotics, is we should still be doing it, but not this way.
Well, I'll tell you, I had a bias for a long time, and my bias was towards large form factor robotics, that in fact, that is what surgical robotics was. But as we queried the market and surgeons and care teams around what was important, what we found was that the surgical arm was not what was important. What they valued was ease of use and CT-based planning. And that if we could give them those two things with a form factor that mirrored what they did in their training and their everyday practice, that in fact the uptake in surgical robotics might improve. And that's where TMINI was born.
Yeah, and now what's subsequently just happened recently was we have separated the need, or at least think as, between locking in the implant and the robot, with what Think has done with the triathlon implant that Stryker has, right? As a surgeon, how do you process that, one, as a surgeon, and two, as a business person?
Yeah, I mean, going back to those two components of the surgery, the technique and the implant, I mean, exactly what you're hitting on. I think what Chris brings up is when you ask the surgeon individual questions about what's important, it's easy for us to say, here are the things that are important. But it's a different question altogether to ask a surgeon who maybe is used to what was in the marketplace, do you believe the small form factor can deliver what the large one does? And I'll be honest with you, I didn't at first. And then once I was able to see and actually use, this handpiece with TMINI, I was blown away. And it can deliver the same level of accuracy and precision while also incorporating all those other components to the procedure. So as a surgeon, as a clinician, it gives you that ability to uncouple the choice between technique and implant, to then bring it back together and say, this is what I want to do. This is what I think the best sum of the parts is. As a business person, it gives you also a little bit more leverage. Options always help you with negotiation, choice, and there is a component to that. There's only a benefit when you have more at your disposal to use. And so that's a real, it's a real factor.
Dr. Sa, when you think about that independence now on behalf of the surgeon, the business, and the patient, that optionality, how are you thinking about that moving forward? And will that be an impetus for us finally to push even to get more technology into implants versus the implant companies maybe sitting on an implant too long because there's not been a leverage point against it?
Yeah, it's a great question, Joe, and I agree with what John said earlier. In terms of being the surgeon, being the clinician, to have the freedom of choice, it has swung the pendulum back to how it used to be for orthopedic surgeons choosing which implant to use in their orthopedic procedures. Back in the day, before the emergence of robotics, surgeons were very loyal to a single implant company. They were committed to a single implant because they believed in that one design, and really many surgeons use only one company, one brand for their entire career. Then robotics came along, and suddenly you had to use the implant that the robotic offered. So if you wanted robotic technology, you're going to sacrifice implant and use what they sold you. And that is how it was for many, many years. And so the pendulum swung where suddenly implant design, implant individuality, those features that the implant companies were promoting were suddenly on the back burner, and it was all about what robotic technology would you want. But now the pendulum's swinging back, where suddenly surgeons have choice. Surgeons can now choose the robotic technology they want to, and they can pair it with an implant that they prefer. So I think what you're going to see, Joe, is that now the differences in implants, the features and designs that are most important for the individual patient, the things the surgeons think are best for the patient, will now come back to the forefront, because now they can pair their ideal robot with the ideal implant. And from a business side, whether you're in the hospital or in the ASC, it's incredibly important to have freedom of choice, as John had mentioned, just for negotiation, for the ability to bring in implants that you think are best for your patient population, but also at a better cost, because certainly that is one of the largest issues with orthopedics, is the cost of the implants. So here suddenly we're able to bring in high-end state-of-the-art technology at reasonable cost and negotiate implant pricing, which makes it better for the patient, the surgeon, and the overall system.
Chris, I'm going to hit you this and both docs. Forever, it was really hard to determine, did we have the right combination on the outcome to the patient? Because it had always been somewhat clouded or biased, because you had to have the implant with the robot. And it was hard to then bifurcate those to say, wait a second, would I get better outcomes if I had my preference of a high-performing implant that may be best for my patient, but then I wouldn't be able to use the robot that it's tied to, unless, of course, you had a Velis and you had a Rosa and you had a TMINI all sitting in, and that becomes cost prohibitive. Do you ever see a day that we're able to have this open ecosystem and finally a registry that would prove that certain implants are better when paired with a certain technology like TMINI?
Yeah, and that's clearly what we're driving at with the open platform and the implant agnostic design. But until we get broad usage, right, that data set's elusive. Number one. Number two, I think that if Think Surgical is successful in this endeavor, that is to divorce the enabling tech from the implant, that changes the equation for the entire industry. Right? I think certainly companies that come behind Think won't think about it in terms of developing a closed platform. Right? That day and that thought ends if Think is successful in this open platform, and all signs point to yes, that will happen. I think it could affect the strategics. I think it could change the way that they think about it, because the old calculus was exactly what Alex said, and that is that we would design and build a robot that tied the surgeon's loyalty tighter to the company, right? Even above and beyond the implant, because clearly what's happening in today's market is that there is a tech implant mismatch. Surgeons are making choices relative to either their tech or the implant, and most often the choice that they're sacrificing is on the implant, right? They're making a tech choice and they're using the implant that comes with it. Opening the platform removes that dilemma, if you will, from the surgeons. On the one hand. On the other, in the operating room and the way that it's used, there's an incredible freedom that occurs for the surgeons. And I love Alex and John's take on it, but I was in Alex's OR for the very first time that I saw TMINI use. And one of his comments to me was that, and I don't know if you recall this, Alex, but that every case when you used a different implant family was just like the previous case, right? And so you didn't have to worry whether your care team or your surgical tech understood the manual instruments for the next implant that you were going to use in the next room, because the case was going to be executed with TMINI, and it was going to be executed just like the case in the room that we were doing. And so it was, I don't know that we intended it that way, but it's been a fantastic byproduct of democratizing sort of the execution of surgical robotics in that platform. And I can come back to the ideas around cost on open platform as well.
Yeah, and that's interesting, and we're going to sort of go between hard tissue, soft tissue. That's one of the areas of resistance is I don't need my care team to have to learn another protocol, another training, another system, right? Another workaround, how to move and not get knocked out by an arm. We'll just stick with this one because my care team doesn't have the cognitive resources to have to spend that all the time. So if I put a TMINI in your hand, as an example that we just mentioned, I remove any of that cognitive load on the team, and I can move in between cases and probably get a higher volume out. Would you say that's reasonable math?
100%. I mean, it allows you the flexibility of choice without sacrificing anything, actually probably gaining on the efficiency side of things, no question. And I think, I lived through this. I bought into the concept of robotics over 10 years ago. And, Chris mentioned that we're seeing surgeons choose, technology over implant most of the time. Actually, at the beginning, it kind of wasn't that. I saw a lot of surgeons resistant to adopt technology because of a strong preference for an implant. And I was the opposite. I bought into the technology, and over time that's changed pretty dramatically to get to the point where, where Chris mentioned, and that is what's happening until recently, where now there's more choice. I think that's really interesting. And I think the other thing, I'd be curious to see what, Alex thinks about this, but I'm curious to see how innovation is driven. I think manufacturers, and allowed might not be the right term, but they're going to have a different focus potentially, because one of the big costs of developing new implants is instruments. And what robotics does, particularly an open platform robot, kind of takes that away a little bit. You can innovate and spend the money on the implant without sacrificing money on developing new instruments. So it becomes a little bit less expensive to drive innovation. That pressure hasn't been there because of the coupling of the two, but now that may be somewhere where the industry goes, and I'd be curious to see what ends up happening.
Dr. Tiberi had mentioned something interesting, and it sort of catalyzed a thought in my head. With TMINI, have you seen peers of yours hold out because their implant was preferred over another, but they could have only used their implant with this robot? Now that we've got an agnostic solution robotically, do you believe that we're going to add to the populace of robotic use in the total joint world, and in particular, let's say knees?
I do, Joe. I think there are some major hurdles to adopting large platform robots. That's why only about 15–20% of the market has adopted the large platform robots to date. Things such as cost and large form factor and interruption of how we typically do our surgeries. You have to change your workflows to adopt to the robot. The training on the staff, things we mentioned, all these are major hurdles. But to have a technology like TMINI, where suddenly surgeons can use implants that they're familiar with, they can have freedom of choice, I think that will gain more adoption. I think all the benefits of the overhead camera, ease of workflow, low footprint, that's really makes this robot a robot for the masses, to be honestly. That other 85%, I think it'll be much easier for them to adopt this. So I think you're going to see an increase in robotic technology use, because this small form factor of the TMINI has all the benefits of the large robots we previously discussed, but it's in an easier, more usable form factor. And to follow up on Chris's point, he was talking about how easy it is to use this technology. For those surgeons who have yet to adopt robotics and orthopedics, when I look at adopting a new technology, really I look at four key elements of adoption in the OR. That would be the surgeon, of course, and the surgeon has to be willing to adopt it. And with TMINI, when we have surgeons visit us in the OR, they're often blown away by how easy it is to use and how much flexibility and power the technology has. So that's one. Number two is the reps prefer it. The reps love it. Even when there are reps who have other large robotic platforms in their portfolio, they find this system much easier to register, to use, to move from room to room. They all prefer it over their large robots. That's number two. Number three are the surgical assistants. Because of the overhead camera, they don't have to move and dodge out of the way of a camera behind them due to line of sight issues. They can hold the retractors where they're used to, position their body where they're used to around the table, because that overhead camera allows surgeons and assistants to use their everyday workflows that they've done even before robotics. So they prefer it. And then fourth are the OR techs and the circulating nurses. Those two groups also prefer it because of ease of registration, ease of use. As we've mentioned, this is not something your team has to learn and they moan and groan and are frustrated about. They will be the first ones to let you know when a surgeon's using a technology they're not happy with. But with this one, they prefer it because it's literally so fast to set up, so easy to use. The OR techs and the circulating nurses prefer this technology. So in our hands, all four aspects of the OR prefer this technology.
Dr. Sa, a question for you, and then Dr. Tiberi after that. What are the dynamics and the decision points as surgeons think about image-based versus imageless selection and decisions, especially when it comes to TMINI and other solutions in the marketplace?
There are pros and cons of both, Joe. And so early in my career, I was a proponent of imageless because it seemed like it would be an advantage in terms of being faster, not having to obtain a preoperative CT, making it easier for our staff to not have to order it or for patients to have to get the CT. But with my experience using some imageless technologies on the market, I found that, at least in my hands, I was not as precise or accurate using it. Because when you're using imageless, obviously you're registering the anatomy during the procedure, but that technology has to make some assumptions. Where are you on cartilage? Where are you not on cartilage? And so in my hands, I found I was recutting some of the bone because I was either too tight or too loose or not exactly where I thought it was. And that might have been my own use of the imageless technology. But what I found was that I would never want to recut when I was using the precision of robotics. So for me, my imageless experience was not what I thought it would be. And then conversely, when I was using image pre-op CT guided technology, I found, to my surprise, that patients, it was not a hurdle for them to get a CT. Patients believe in the technology and they will travel a distance. They'll take time out of their day. They'll even pay out of pocket because it's relatively inexpensive to get these pre-op CTs because they want the best technology and best outcomes in their knee surgery. So they're very happy to get the pre-op CT, so it was not a hurdle. And then with the precision of the CT, I found that the ability to execute the technology with image-guided robotic technology was much more precise in my hands. Don't have to recut. You know exactly what angles and positions you're putting these implants to the half degree and half millimeter. So my hurdles to adopting a pre-op CT image-guided robotic technology were quickly found not to be true, and I actually prefer image guided. So to this day, I tell people I would much rather have an image guided technology than an imageless.
Dr. Tiberi, your thoughts on it, and has the accelerated technology trajectory we've seen helped that decision?
I think all else being equal, it would be better not to have the image basis. I think the truth of the situation is not all else is equal. There's really two components to the imaging. There's what you get from the plan, and then there's the intraoperative accuracy precision component. So Alex touched on the intraoperative accuracy and precision, and the fact of the matter is, as many surgeries as we do, as much as we do the registration, there's always the possibility of human error. We're surgeons, but we're humans. The image basis removes that to a large degree. You perform the intraoperative registration and there's a check. You know that you're accurate before you proceed. So you know that you're basing your entire surgical procedure on accurate information. I just think that can't be replicated right now without an imaging basis. The plan, when I first started with robotics, there was a surgeon who really encouraged me to do so. He was on the verge of retirement. So he believed in this concept and he didn't have the ability to really use it himself. One of the things he said to me is, you will be surprised about how much you learn from this. And to a large degree that came from the imaging. Those preoperative plans over the past 10 plus years, I have learned so much, not just on an individual case basis on how am I going to do that procedure, how am I going to take care of this patient, but also how much have I learned in general about doing a knee replacement, doing hip replacement, and it's really been true. So I think for now, it serves a really large role in helping us achieve what we want.
Chris, there's all kinds of projections right now about adoption of robotics in hard tissue. And there's two stats. There's the number of procedures that are done with robotics, and then there's the number of surgeons who use robotics to do procedures. And sometimes people intermingle those to their benefit. So what do you think the roadmap looks like ramping up to 2030 or so?
Yeah, so there are several data points out there to suggest that we go from somewhere less than 30% today adoption, and again we can talk about whether that's by surgeon or by volume or some mix of that, to something that looks like 50 to 70% by 2030. So a potential doubling of today's penetration of surgical robotics. But I think to get there, you have to do a few things, and I think Alex and John have touched on it. The first is you have to have a form factor that is easy to adopt. Right? Today, only Stryker has meaningfully adopted robotics into its implant family. Right? They're at 65 to 70% adoption on triathlon utilization. No one else is above the mid-teens from that perspective. And that says something about the quality of systems offered. It can't just be about Stryker's better at selling that much more than, say, Zimmer Biomet or DePuy. I don't believe that's true. It says good things about the Mako system. A lot of the things that the Mako system has done well, that John and Alex have just touched on, is how well it lets the surgeon plan the case and then execute the case in exactly the way that they want to do it with confidence. We think that TMINI bridges that because it then opens up this idea of implant choice, right? Because if I'm a Zimmer Biomet user, or if I'm a DePuy user, or if I'm a Medacta or a Novus user, the option to use image-based robotics had previously been closed to me. And that's the democratization that TMINI offers. That, I think, is the missing piece that enables us to go from something that looks like 25 to 30% adoption today to 50 to 70% by 2030. I think to get to 50 to 70% market penetration in robotics, you have to have full coverage across the implant families that matter. Today, we have a dual channel strategy for penetration of TMINI into the market. That is, we have a distribution agreement with Zimmer Biomet and a fantastic partnership with that organization. They represent about 32% of the market. The open platform, on the other hand, has 8 implant partners with us that comprise about 7 to 9% of the market. And then, of course, we announced compatibility with Stryker and Triathlon, which is another 30 to 32% of the market, giving us roughly 70% market coverage today, with plans to move to close to 100 by the end of the year with the addition of the other 2 strategics onto the TMINI platform.
Let's talk about subset users here, because there was a recent announcement made, and there's that concept of 0 to 1 is tough, 1 to 100 is tougher in a different way. But I believe with a limited market release in 2024, and correct me if I get the numbers incorrect or the timing, it took us about a year to get our first 1,000 cases under our belt. And then the following year, 12 months later roughly, we hit case number 5,000.
That's right.
So that's sending a signal that there's adoption and ongoing utilization in the marketplace today. Are those numbers correct?
They are, and you're right. Roughly a year of real commercialization to get to 1,000, 4,000 more over this intervening 12 months from the time that we announced our 1,000th case. I think Dr. Tiberi got the 5,000th case, so congratulations, John, on that. In that time, Alex got his 1,000th case. He's been a fantastic user of TMINI. And I think you'll see 10,000 much faster than you saw 5,000. The ramp is turning upwards nicely.
And so as we close out this conversation, Dr. Zah, what would you want to leave with the audience, with your peers, and even maybe as important, the manufacturers who put the tools in your hand and the implants in your hand? What would you want to leave them to think about?
Yeah, I would tell surgeons who are thinking about robotic technology that now's the time. There's clearly benefits to it. It allows you to execute a more precise plan. You have the ability to individualize the procedure for the patient's soft tissue balance using the technology. So now's the time to adopt robotic technology. And the TMINI is one that is really for the masses, as I said. When I have surgeons come to my OR, I show them how easy it is to use for me and my team. But also I describe to them how it makes every case really the same case. I call it the great equalizer, because whether you have a small mobile lady knee or a really stiff and difficult man's knee or major deformity or prior hardware, no matter how difficult the case is, the workflow of this technology is you need very small exposure just to place the pins to execute the plan, which is based on the 3D pre-op CT. So it makes every case the same easy case. And so I think that's where surgeons really will find the benefit. It's truly a robot for the masses where anyone can adopt it, whether you're an experienced surgeon, having done robotics before, never done robotics, or you're a resident or a fellow coming out of training. And for the implant companies, I would tell them, let the technology companies develop the technology. Let the implant companies go back to focusing on the implant design, because now with this open platform concept, the design is going to become the distinguishing feature. It's going to go back. The pendulum's going to swing back, so that surgeons are going to choose their preferred technology and pair it with their preferred implant. So the implant companies should go back to focusing on their unique features.
Dr. Tiberi, your message to the market, peers, and the manufacturers.
My message to my peers would be, I certainly believed that the time, was 10 years ago, but now I would say, like Alex said, the time's now, and many, I can't say all, but many of the barriers are removed. So even more now than ever. To the market, I would say that, and one of the things I tell a patient is, robotics as a really sophisticated tool for me to achieve the goals I want to achieve takes away nothing. When I'm in surgery, I don't remove anything because I'm using a robot, but I'm adding an extremely sophisticated tool. And if you think about it that way, why wouldn't you use it in every case? And to the implant companies, I think the same thing, that Alex said, I touched on before, let the technology allow you to innovate, because now that's where the focus kind of needs to be. And also, you can do it with less of a cost without the instrument cost.
And Chris, so we're here in middle of May 2026. Obviously, Think has had a fabulous last 12, 24-month run on the adoption here. Where do we go from here as a platform technology, right? This is a heck of a opening play.
Yeah.
Where do we go from here?
Well, look, I think a lot is still to be determined on where else TMINI and Think Surgical in general can add value. We'll continue to focus on excellence in total knee arthroplasty. Right? I mean, that's where our mission lies. And there's some things we can do that in conversations with our clinicians like John and Alex, that can make us better than we are today, right? So we'll focus in the near term on TMINI and how it provides value to surgeons and patients. We'll see where the platform goes. There are absolutely adjacent indications that we think we can add value to, but we'll have to see how this development of TKA goes. Let me add one thought to John and Alex's comment on the message to the market. You know, there is another stakeholder that's not around this table today, and that's healthcare executives. And at the hospital level and at the IDN level, the concept of open platform robotics holds other value outside of standardization of care. And that's the economic question of, does an open platform system give them back control, number one, of the technology offerings in their OR, right? So you no longer have 3 or 4 or 5 technologies, depending upon the number of surgeons' choices that you have in your institution, lined up down the hallway on the one hand, and all the attendant costs that come with that, when you might be able to have one platform that services all of those clinical needs. And on the other, you know, one of the things that's happened over the last 5 years in particular is that there has been a rise in placement agreements and usage agreements for technology. And it began, I think, well-intentioned in the sense that capital dollars are always hard to come by. There's technologies in every facet of medicine that are looking for the use of those capital dollars. And so implant companies, I think, thought, well, look, maybe we'll place them and we'll not ask you for capital dollars, but we'll spread that cost of the capital acquisition across a usage agreement, which requires volume at a certain rate and price at a certain level. Looks good in year 1, looks different in year 6. And one of the messages that we've gotten consistently over the last 24 months is, if you could help me regain control of my OpEx, I'm interested. And so that means a redeployment of capital in a way that has changed maybe in the last 5 years. But I think that's a change that the healthcare executives are actually looking for broadly. And I think that's the other factor beyond what the real clinical benefits that we've spoken about today that TMINI can bring.
And this is interesting too, because if we think about the big players right now in the robotics, like the big 3, let's just call it on the implant side, they were never a digital first organization. They were an implant first organization. And they actually acquired the technology, but it was never native to them. So they never had to ask the questions because they were already locked into a solution.
That's right.
Where it feels like Think came in and said, wait a minute, we're not going to buy into this monolithic structure. We're going to ask different questions, and we're going to solicit the surgeons as to, now that you've got this, how about this? And it puts you in a much more powerful situation, and you don't have to protect a citadel. You can actually become a lot more agile. And then now the surgeons have seen this and say, wait a second, this is the way forward. So it'll be interesting to watch how Think Surgical moves that sort of leverage point forward and how the market responds to it. So, gentlemen, I thank you for your time today. I thank you for the candor and the insights into the market. And I know our audience does as well. Thank you.
Thank you, Joe.
Thank you.
I'm Joe Mullings from 160 Studios. Be well.